I'm Bryn Lloyd-Evans, as Sonia said, but I'm really presenting this on behalf of our Policy Research Unit colleague, Dr. Una Foy, who is presenting downstairs in one of the other sessions, but she led this work. And like all our Policy Research Unit works, it's the product of a large team, including our colleagues from the Lived Experience Working Group who have contributed. So most of the talks that you're going to hear in this session have quite a wide lens, that they're looking at international service models or implementation of crisis care. But this project, we're looking at a more granular level, really, about trying to make service improvement and innovation in crisis care systems work within local systems. And all the projects that were the focus of this project were funded under this one Department of Health and Social Care scheme, beyond Places of Safety funding scheme. And I'll say a bit more about that in a minute. It's not moving on.
Try bringing it.
Yeah, good. Thank you. Okay, so this is a fairly elderly study now, the CQC survey. But
you're not near enough to a microphone, sorry.
We'll get that. Is that good? All right, thank you. It's good. Okay. But I think this survey done by the CQC really just brought home kind of some salient points about mental health crisis care that sparked a lot of initiatives since, really, about trying to improve things. So lots of people don't know where to go, where to get help in a crisis. And the second stat there was only 14% of people thought they got the right help in a mental health crisis. And that's obviously not great, isn't it, really? So that sparked a lot of initiatives since to try and improve things. How do I move it forward?
Maybe you have to move it down here. Actually, you tell me when you want it moved.
So, okay.
Give me the mouse.
Yeah. Okay. And so one small scheme about this was this Beyond Places of Safety scheme funded by the Department of Health and Social Care. So this is as you may guess, a sort of follow-up to a previous funding, Places of Safety. And in the scheme of things, it was a reasonably small initiative. So they had 15 million quid, which sounds like a lot, but in terms of the overall crisis care budget, it isn't, which local NHS trusts and voluntary, or in collaboration with local authorities and voluntary sector organisations, could bid for, to have to innovate really in that crisis care system and put in place new services which could improve the sort of access to care and the offer for people in mental health crisis. And so 50 projects were commissioned with this in 2019, which was a whole range of crisis care services. And we'll say more about the ones that we looked at, but essentially ranging from digital sort of online help in a crisis cafes, through to sort of formal services like Section 136 suites, where the police can bring people to a place of safety if need be. That's good one, thank you. So what we aimed to do really was to try and talk to the managers of these new innovative services who are running these innovations in mental health care, to try and understand from them really how it is trying to, on the ground, improve mental health crisis services within your local system, and to understand from people what helped and what got in the way of trying to innovate and improve mental health care. So we conducted interviews with the managers of these projects that were funded by the BPOS and Places of Safety scheme, to explore with them kind of really what were they aiming to do, how far were they able to achieve their aims, and what helped and hindered. And we used a kind of implementation science framework about looking at the sort of barriers and facilitators of what helped, which distinguishes the features of the innovation, the service itself, the people involved, the inner setting, which is the sort of service support, and the outer setting, the broader societal and service context. And we actually managed to interview sort of 18 of these managers from a range of services. So we move on. Thank you. Which were, as you can see here, slightly a mixed bag. So crisis cafes and safe havens, which are places in the community where people can generally just go, or at least sort of phone and then go to in a crisis. Online services, trying to sort of join things together better in multi-agency hubs, and specific assessment suites, often within hospitals or A&E services, for supporting people in crisis. But I think they did have these two things in common, really, that really what the managers told us were the aims of these services were to try to improve safety for people in mental health services and to relieve some of the pressure on either people needing to be admitted to hospital or to go to busy A&E wards, which are, you know, often not a great environment for people to be seen in a mental health crisis as well, or to sort of relieve some of the pressures on the police to sort of manage people in crisis as well. Let's move on if that's okay. So here's a really quick slide, just one slide summary of the results. I'll try and sort of be succinct. So the bit on the right is really just to show you that we did use our implementation science framework and do it rigorously. But some of the key findings we heard from the managers really about what helped. And I think the first one here is this idea of bottom-up development, that people really liked the idea that this was a funding source where people could bid for the money for something that they perceived as being useful in their local service system. So this was something that they wanted locally and had been driven from that rather than some edict coming down to the services from higher up. And things that then made it work and so it really got buy-in and got things going where people said it was really important to involve people with lived experience, so people using services to help design the service, to find out what the needs were and how this service might be best set up to make things work well. Managers also told us it was just hugely important to get all the agencies, all the stakeholder groups involved, buying into this and to talk to people about what their needs were. So that's both within health services, if you're trying to provide something that links in with other crisis services and new services, then you have to talk to those other crisis services and make sure that they know that and are okay with what you're suggesting. But also if you're trying to signpost people on to voluntary sector organisations, you probably need to sort of make sure that they are sort of equipped to deal with the people you're signposting to and are happy with that and so on. Okay. And then the other crucial thing was about leadership as well, and having sort of senior leadership buy-in was essential. Things that got in the way, people recognized digital things are harder to implement than anyone realizes. They all prove complex. Getting the right staff, but also the right staff with the right skill sets was really crucial. Capital funding only gets you the sort of basic sort of thing to set up, and then the ongoing staff costs have to be found within the organization, and that was challenging. And this small global pandemic kind of complicated stuff as well for people. Now go on. So I think in conclusion really is just this was really interesting that there's obviously a role in policy for trying to sort of make evidence-based care implemented consistently across the board and to say this is how it should be. But I think we heard in this scheme that a modest capital funding scheme to let local services say this is what we need and to innovate is really valued and useful, and that kind of bottom-up approach is helpful. And leadership, staffing and co-production are three key messages. Move on. As with all our papers, we had a lived experience commentary, so we had lived experience colleagues working on the whole project, but this was some key learning that they picked out, and Bev Chip wrote this one. So a real sort of bottom line without which nothing works in crisis care is you have to know where to go in a crisis, and that's a kind of crucial thing. So investment at that front end of where do you first get help when you need it is really important. Co-production is really important. A lot of managers told us about trying to do something different from kind of a clinical care and have a different environment, and peer workers are well set up to provide that slightly more friendly, welcoming, informal approach to care. One more slide. This last one. We work with policy colleague in this. So the leader of the Beyond Places of Safety scheme, Jeremy Clark, had two things. First of all, he said it was really helpful to get an independent kind of validation of what they thought they'd heard from services about this being useful money. But he also said he learned a lot, mainly from our lived experience colleagues, really about looking carefully at inequalities and co-production in all how you think, how you plan services and how you commission them. And he said he'll take that forward. So hopefully some wider learning. So that's it from me.
Thank you very much. So now the baton is being seamlessly handed over to Kitty Saunders, another of our fantastic postdocs. I'll change the slides maybe.
Well, I'm much shorter than our previous speakers, obviously. Hi, everyone. Yeah, I'm going to talk to you about a scoping review that we did at the Crew on trauma-informed care in acute, inpatient, emergency, residential mental health services. It was me, but a whole host of others as well. We had several research questions, but really our primary one, and really the reason why we chose to do a scoping review, was that we wanted to map the trauma-informed approaches that we use in these specific mental health care settings, where we know people who've experienced trauma are quite likely to present, and also services themselves, which are quite likely to be traumatizing. Additional questions included things about outcomes, like experiences and expectations, well-being practices, service use and cost effectiveness. Thanks, Sonia. So we followed all the steps that you should when you do a scoping review. We registered the protocol, we searched 7 databases, we consulted experts. We got about 4,500 studies through those processes, and then narrowed them down to 31 included studies. And we've just found out that the paper is being accepted in BMC psychiatry. After a really long time. So the characteristics of the studies that we brought back, basically really US-centric data, very little data in emergency services, actually none. The research was primarily conducted in acute and residential services. Quite a high proportion of child and adolescent services, so 12 of the 31. There was a fifth in women's only services, and out of 31 studies, 21 studies did not define what they meant by trauma, which we thought was quite staggering. We identified lots of models, but I can't walk through all of them because I don't have time. But the main two that we identified were the sanctuary model and the 6 core strategies. These were the most numerous across the research that we identified. The sanctuary model is a kind of blueprint organizational change approach where they aim to create a trauma-informed culture within a service and let all the good stuff kind of drip through that. The 6 core strategies is about reducing restraint and seclusion in locations where that is likely to happen in a trauma-informed and evidence-based way. Thank you, Sonia. And the kind of key findings, there were very little kind of good definitions of trauma available. And that's quite surprising, and it raised a lot of conversation in our working groups about how can we develop something that's trauma informed if we don't define what trauma means? And that's a really, really important point for all of us to think about when we're thinking about taking these things forward into services, implementing them in a larger way. Do we even actually know what we're trying to help? Service users reported feeling more cared for, more trusted and more trusting in trauma-informed care approach settings. There were improvements in restraint and seclusion rates, particularly for those 6 core strategies settings, which is maybe not surprising, that's what they were aiming to do. And people also reported feeling more able to engage with their traumatic experiences, but also actually reported understanding a bit more what constituted trauma. Having gone through difficult times, not understanding that actually quite a lot of the stuff they'd gone through met this criteria, and that they deserved care and they deserved support for that in itself, which is really important. One caveat I will say is that we identified very few trials, so very few comparison groups, very few kind of randomized designs. So we need to really take all of these findings with a pinch of salt. They're quite observational, but they're trending in a direction that we would see as quite positive. So the implications, what can we really say about this? We had lots of discussions in our working group about how trauma-informed care principles are really quite basic human rights principles, really at the core, that really we should be empathizing and caring for people who have had difficult experiences, who then have mental health issues. And really we argue that they should be central in all mental health services. Implementation of trauma-informed care was complicated, and it required strong commitment and strong leadership to enact this kind of organizational change, and there needed to be appropriate training and supervision. As with all good approaches, they need to be implemented appropriately. There was very little evidence of service user involvement in any of the studies or any of the implementation of trauma-informed care in the studies that we looked at, and really that needs to be centralized in any future research that we do in this area, and any further implementation that we do in this area also. Thanks, Sonia. And we found nothing about emergency settings, which is quite kind of possible place for people who've experienced trauma and also to have mental health problems to appear. So we really need to think more about what that might look like. So this is from our lived experience commentary written by Rachel, and Rachel's here today, so maybe you can chat to her. I think this is really powerful. A version of trauma-informed care implemented in an under-resourced, fundamentally carceral system carries all the risks of harm associated with that system, with the added gaslighting of framing it as trauma-informed harm. As such, everyone involved in providing care they view as trauma-informed should consider what power over our stories and our bodies they're willing and able to give back. Please go and see the poster with the full commentary downstairs when you have a moment. Thank you very much.
Thank you.
Okay, so now we have Antonio Rojas Garcia, our Senior Research Fellow, taking over a further piece of PRU work.
Hi, hello everyone. It's a pleasure for me to be presenting this investigation we have run in the unit, in which we are trying to look at the association between the characteristic of the local crisis care systems and service use using a English national survey. Okay, the background for this research is the development and implementation of mental health service that effectively help to avoid unnecessary acute admission has been something of interest for policymakers and researchers in the last few decades. There are three community service models that have been well established in England and internationally, which are the crisis resolution and home treatment teams, the acute day units, and crisis houses, non-hospital residential crisis care services. The development of this type of models in the UK has led to an increased variability in the models and services that has been implementing and how they have been organized as a whole. And to conduct this analysis, we used this data from this national survey in 2019, and we defined two research questions. The first one, what type of mental health crisis systems are there in England? And the second question was which characteristic of these crisis care systems are associated to admissions and detention rates. We split this second research question in two. We derive three theoretically derived variables describing they were access, integration, and choice, and we wanted to check if they were associated to admissions and detentions at CCG level. And then we look at this crisis characteristic of the system of the service models individually and how they were associated to admissions and detention rates. Okay, yeah. Well, here the methods we use were first summarizing the frequency of the service models and the system characteristics. And for the research question one, we use a latent class analysis to try to find patterns to organize the systems. And for the second research question, we use a mixed effects negative binomial regression model. Here we have, sorry, I forgot something. Well, we extract the data from for admissions and detentions, and for the covariates from Public Health England fingertips. Yeah, and here we have the summary of the characteristic of the service models and system characteristic, and In the first column, we have the number of CCGs providing this information, and in the second, were present this characteristic. After we ran the latent class analysis, we ended up with models that did not converge. When these models converge, it was kind of hard to interpret. It didn't make a lot of sense theoretically. And there was no evidence that models with 2 and 3 classes were better than the models with 1 class. For the second research question, the first one, as I said before, we derived these variables. We did not find any statistically significant association with admissions and detentions. But when we ran this mixed effect model for the characteristics of the system model, after adjusting for the model, the covariate, we found that the crisis telephone line was related to a 11.6% lower rate in health admissions and a 15.3 lower rate of mental health attentions. Also, provision of crisis cafe was associated to 7.8% lower rate of admissions, and the presence of crisis assessment team separated from the crisis resolution and home treatment service was associated to a 12.8% higher rate of admissions. We presented these findings to our life experience working group, and they provided like really useful comments. First, they welcome this research. They consider that it was like needed. But they mentioned that only focusing on admissions, admissions is an essential part of crisis care, but this research should be expanded in the future to consider other type of outcomes. They also mentioned that variability of these services cannot be captured. As an example, they said that crisis houses and cafes can be run by NHS, the third sector, or peer run. That the findings of crisis telephone lines reducing admissions may be of interest given the variation between the different areas. Also, that it would be relevant or important to compare the children and young people services with the adult services. And finally, that the COVID-19 pandemic has led to increasing funding for services and for certain co-production research. And as we use this national survey from 2019, this might have changed now, possibly. And finally, the implications of this research is, the configuration of the crisis care systems varies considerably in England. We did not find any pattern or way of grouping this characteristic of the systems. The provision of crisis telephone service and crisis cafe might be associated to a lower rate in psychiatric admission. Crisis assessment teams separated from home treatment teams may not be associated to this reduction in hospital admissions and detentions. And finally, that we need more research to identify potential crisis care system configurations and how we can implement this in a better way.
Thank you very much. Okay, and last but not least, Gergo Bartle is going to talk about some work on the Mental Health Act. Thank you.
So, as I mentioned, this is a piece of work we've conducted in the last few months with the Department of Health and Social Care regarding how to measure service users' experiences who've experienced a mental health act process, for example, admission or community treatment. As Bryn has mentioned, sorry. Talk a bit louder. I think that's usually the feedback I get in classes. So I'll do my best. As Bryn mentioned, this has been the work of quite a few of us in Proof. So you see all our colleagues, most of our contributors on the screen. But just to give you a bit of a context on the first slide, so the Independent Mental Health Act review a few years ago has set out a number of principles in which way the Mental Health Act processes could be improved. So this is something that's currently in the state of a draft mental health bill. So there are a number of proposed changes to improve processes, for example, revising the criteria for detention, giving people more of a say in who's involved in their care, giving people more of a say in what treatment they receive in the form of advanced statements or access to their care and treatment plans, and the review of a number of mental health act related processes. So in terms of the aims, what the Department of Health and Social Care is aiming to do is to quantify and measure service users' experiences if they experience a mental health act related admission or treatment, to be able to quantify and track any impact that's due to legislative changes, to measure the impact of legislative change. So what we've been asked to do at PRU is to seek advice and consult relevant stakeholders in identifying what would be key experiences and topics that should be included in such a survey of service users, inpatient and community experiences, and how should such data collection be conducted in terms of data collection methods and questions asked. So we see, yeah, and then the next slide, so yeah. So in terms of how we set about looking at important topics, looking at ways of collecting data on service user experiences, we had two streams of work. One was scoping and reviewing existing literature, so that involved reviews of academic peer-reviewed qualitative papers, but also grey literature, not academic papers, as well as looking at existing patient satisfaction surveys and current clinical practices. And another important part of our work was to consult relevant stakeholders, so people with lived experience, people who have clinical experience, and that took the form in terms of online workshops, consultation workshops, one with 40 people who had a lived experience of a mental health act admission, either as a service user or a carer. And we had another separate workshop that involved 24 stakeholders with a variety of backgrounds, including lived experience of mental health problems, or being a clinician, being a researcher in the field. And do you mind if you jump to the next slide? So there's just two versions of that. So in terms of what we've heard, in terms of what topics should be prioritized in any survey of people's inpatient or mental health act experience, people value if they are feeling listened to, if they're treated with dignity and respect. And there's also negative experiences that people felt important to track, for example, experiences of coercion, experiences of discrimination, particularly very topical in the UK, discrimination due to racism, in addition to some procedural aspects like access to information, access to advocacy, or having feedback taken seriously. If you can jump a couple of slides. So we also spoken to people who were carers of people who have experienced a mental health admission, and in terms of what they found priority items, being involved in their loved ones' care or providing information, being provided information on the processes and rights. There's also an important aspect that seemed to be about how information is shared between the team and the carer, so that two-way communication, people felt important in their experience. And also another key aspect was what support was available for carers to continue their caring role, as well as support for themselves as individuals going through a difficult period. So in terms of how a survey might approach asking questions about these topics, we've scoped relevant literature. So we had a look at existing satisfaction surveys, clinical and academic surveys alike. And we also sought advice from clinical colleagues, intellectual disability colleagues. And generally, the advice was to keep the survey as simple, keep the number of items that are asked in a survey short, keep response options brief. For example, 3 options are better than many, and generally to use a simple and clear language, because that enhances inclusivity and it might also have a positive effect on response rates. Thank you. In terms of when such a survey should be conducted, we know that there are a number of key parts of the admission process, and that was also the feedback from the workshop. So how people are initially assessed, was their inpatient admission experience, was their discharge or post-discharge care like? So it seems like a number of different stages need to be captured. So what seemed to be a potentially best approach is a snapshot of care approach. So to have a certain period in a year, for example, a month, when people at different stages of the mental health act process are asked to provide feedback. So all these time points would be in such way captured. And there's also a benefit of a large-scale data collection. So expected response rates are low. There are a number of different services where people may experience mental health act related processes. So large-scale data collection would ensure that there's sufficient information captured to be able to track what people's experiences are in different services. In terms of the feedback we got in terms of how to collect data, it seems like there's no single solution. Digital approaches seem to be quite easy to implement. They have an advantage in terms of confidentiality, in terms of rollout, but it may not suit everyone. So there's also a case for having alternatives like old-fashioned paper surveys or phone-based data collection. One thing that we've heard clearly from feedback is that people want to ensure that people who give feedback can do this in confidence. So there's an independence of completion. So ideally this would be independent from, for example, ward staff, where people are receiving their care. And if there's any support needed for the completion of questionnaire, the advice we were given was to give training to people so they're sufficiently skilled to answer any questions that people may have about the questionnaire. This is where peer workers, advocacy workers, or patient involvement colleagues may have a role in terms of providing some independence. So in terms of a large-scale cross-sectional observational survey, it has some potential weaknesses. We've mentioned potentially low response rates. Also in terms of access of certain groups may be more difficult in a large-scale survey. And also, if our aim is to track changes over time due to mental health act related reform, it may be that some of the changes picked up are due to some other factors. So there's just something that's a potential weakness of such design. In terms of the work that we've did, we had limitations of our work. We had quite a short period of time available for this. So we tried to be thorough, but we're likely to be not to have been exhaustive. For example, specific input from all the groups, intellectual disability groups, or current NHS practitioners may have been more limited than we would have ideally wanted it to be in a longer consultation process. But yeah, in terms of next steps, we have compiled and submitted a report that we're aiming to also make available online shortly when it's possible. And this is now being reviewed by the Department of Health and Social Care, with some potential role for us to be involved if there's any refinement needed. But ideally, what we're expecting to see is a survey rolled out at multiple time points for people experiencing mental health act-related admissions and community treatment, to track their experiences over time and be able to track any changes that are due to the pending mental health act reform. So thank you very much. And just to say a big thanks, there were a lot of people involved, both in this project, both from a PRU as well as lived experience and clinician colleagues, policy stakeholders, civil service partners. So thanks a lot for all of them for their input.
Thank you. Okay. Thank you very much to all our excellent presenters from the team, and especially as you've actually caught up and we finished marginally early, having started late. So that's a bit of an achievement. So we now have a quick coffee break, followed by a panel discussion with a number of perspectives on how the acute care system can be improved. So this is going to be a panel discussion in which we're going to start by inviting each of our panelists, who I'll introduce when they come to speak, to answer a question that we've prepared for them. And then after that, Q&A from people in the room, and also we're inviting questions via the chat from people who are out there on Zoom. So we do want to include you too, online audience. Okay, so our first panelist is Rachel Rowan Olive, who's a lived experience researcher and a member of our LUG, as well as being an illustrator, campaigner, trainer and linguist. And my question for her is, what should the priorities be for research and policy to improve acute care? Thank you, Rachel.
Thanks. Obviously, that's a really huge question. And I guess I have a couple of things. One is specific to inpatient care, and the other is kind of a general principle. So I'll start with the general one. I feel like we've done a lot of research that has looked at like, what's the best model for how to kind of fix things or improve things at least. I think that's really interesting, but I would like to kind of do more primary research that starts from what's happening now. And maybe looks at how does that match up to the models that and the policies that we have, because I feel like there's a really, really big gap. There was a paper that Sonia and Bryn worked on like many years ago now, looking at crisis teams implementation and kind of doing a national survey of like what the policy was and what was actually happening. I think it would be really interesting to do that for a lot of other kind of innovations in acute care. Because I guess I read the papers about stuff and I don't necessarily recognize my experience and my friend's experience of like how places like crisis houses, say, are used. And I guess in relation, the other thing that I've been thinking about is specific to inpatient care. And I guess I want to like add a caveat before I start talking about it, that like ultimately I don't want hospitals to exist. Like after the revolution, none of it's going to look like this. But like in the meantime, we are being admitted to hospital, whether we want to be or not, and it's doing a huge amount of harm. And I think that harm is worth minimizing. So I am really interested in how wards and acute settings in general respond to self-harm, because I and various friends have experienced really different approaches to it. Some of which I can only really make sense of via like really crude behaviorist principles of like, this is attention seeking, and if we ignore it, they'll stop. And some of which have been very punitive, some of which have been very restrictive, but like, and I don't know that that's always the wrong way to respond, but it's also not always the right way to respond. And I think there's probably a lot of like local policies about that, like a specific ward will be like, we deal with self-harm in this way, or like a specific trust will have a really particular way of responding to it. And like there's always this tension between local and national policy, right? I don't know that we should have a national self-harm on inpatient wards policy. I don't know that that's necessarily what's going to minimize the harm, but it feels like at the moment there's inconsistency in a way that is not responding to anything other than chance, like where you happen to end up. And I also think there's a lot of inconsistency in terms of really basic stuff, like, does anyone know where the defibrillator is? Does anyone know where the dressings are? Does anyone know how to remove stitches? Like, sorry, but if you're a nurse and you can't remove stitches, what are you doing? But it's really common. And I think, so there's scope for work on like examining basics like that, but also more kind of in-depth stuff around harm minimization, because I've seen work on harm minimization that really grapples with it and grapples with the difficulty of it, and the potential risks and the potential benefits. And it's always seemed to me that acute settings are probably the settings where that's most helpful, because that's the point where it makes most sense to say to someone like, I believe that you can live without self-harm in the future, but I understand that you can't stop right now. And we need to find a way to make this as little harmful to you as possible. But that relies on a really solid therapeutic relationship that I think is missing in a lot of acute settings. And I think research on kind of exploratory research on how can we create that? How can we do that in a way that doesn't sanction neglect, which is already a huge risk? I would love to see that. So, I mean, that'll keep us going for a while.
Great. Thank you very much. So next, I didn't apologize, by the way, at the beginning, that we actually unfortunately have lost two of our panelists, which is rather careless. Unfortunately, Bobby Pratap and Chris Lynch, neither of them can in the end make it today. However, we have got 5 rather magnificent panelists, so I'm sure no one will be unhappy with the lineup we do have. So I'd like to introduce next Jackie Dyer. Is that all right? I've reordered people following dropout, who's an independent health and social care consultant, a campaigner, and has been, and I think still is, equalities champion for NHS England. And Jackie, I'd like to ask you, how do you think research can possibly help to address failures of inpatient services to provide humane and equitable care? Thank you.
Okay, so good afternoon, everybody.
Yes.
Wow, you can't even speak, right? You're speechless. Good afternoon, everybody. Thank you. Okay, so I'd like to start actually with lived experience, because that's why I'm even here. So my own lived experience of mental health challenges and that of my siblings for well over 30 years, and 3 siblings that have experienced severe mental health challenges, 2 of which passed away, one at the age of 41 and one at the age of 54, Barry and Carlton. And my sister is still living with mental health challenges. So for me, when we're talking about failures of inpatient services and mental health services more generally, that's my lived experience in terms of their ability to provide humane and equitable care. Because if that was what the provision was like, then my siblings would still be here. And more recently, at the beginning of this year, my aunt, who was detained under the Mental Health Act, she's had mental health challenges for many, many years. And she stopped eating, so they were feeding her by tube whilst she was detained. But on this occasion, instead of the tube going in to help her to eat, it went into her lung and killed her. So and unfortunately, we as a family are not even surprised by that, because that is our experience and our knowledge and our awareness of what happens to the Black body, quite frankly. So this is not an intellectual question in a sense. This is a very much about grappling inhumanity and inequitable failure of inpatient mental health services. So how can research help that kind of failure? I don't know if I have all the answers, or even if I do have an answer to that question, but I do think that it's important to have research closer to helping to improve practice of what is delivered within mental health settings, and that there isn't such a gulf in that arena. So one of the things that I'm involved in is and how important it is to pay attention to the differential experiences of people according to, we can use the protected characteristics of the Equality Act, but paying attention to what oft happens in terms of the power differential within mental health service provision, and in particular inpatient settings, is systems of oppression manifesting themselves relentlessly in these spaces with no attention to that differential experience. And I would like a research that is more sophisticated in being able to attend to those differential experiences in terms of access, experience and outcomes for people according to their protected characteristics and according to their intersectionalities. I would like to see that. And I would also like to see research coming closer perhaps to working with myself in terms of, I lead an Advancing Mental Health Equalities Task Force with NHS England, and I lead on the Patient and Carer Race Equality Framework. The Patient and Carer Race Equality Framework was a recommendation from the Mental Health Act Review around which many of you will know that the Mental Health Act Review, the terms of reference, there were two key items in there that warranted closer attention to the racialized experience. One was the rising levels of detention under the Mental Health Act that we know is disproportionately with racialized communities. And the other is the overrepresentation of people in inpatient wards from Black, Asian and minoritized groups. And I was a member of the Mental Health Act Review and lobbied for a subgroup to pay particular attention to the Black and Asian experience. And from that emerged two key recommendations. One is culturally appropriate advocacy, which the government is leading on the pilots, and two, the Patient and Carer Race Equality Framework, which I lead nationally. And that PCREF acronym is an anti-racism framework, a race equity accountability framework, and it will be rolled out as mandatory next year, 2024. We've got pilot sites across the country and early adopters, because we've essentially co-produced the framework. And the framework is in three parts. Part one is around leadership and governance, which is statutory and regulatory responsibilities, essentially. Part two is around organizational competencies, one of those organizational competencies is co-production, which is being talked about today. But there are other organizational competencies that interact with co-production. Co-production in and of itself is not going to address the racialized experience, and we've got to be careful of going away on red herrings, not to say that it's not an important aspect, but it is in interdependency with paying attention to what the data is saying, both quantitatively and qualitatively, which is what the data is saying in part one around the Mental Health Act implementation, Use of Force Act implementation, culturally appropriate advocacy feedback, etc. And part three, which is the patient and carer feedback mechanism. And actually, I got a good little pointer today from that piece of research. I'm looking at how do we sort of pull that together with what we're developing for that feedback mechanism. That was really, I'm so glad I came here and listened to that today, because my mission is about bringing research really closer to practice. But the organizational competencies, cultural awareness, co-learning, co-production, paying attention to the workforce, paying attention to data, etc. And this is the engine room to help change the trajectory of what the data is saying in part one and part three. So for me, how do we get research closer to influencing, making our inpatient services humane and equitable, is a systemic and a systematic venture of which I hope that we can achieve.
Thank you very much. And so number three is Karen Newbigin, who's a senior researcher currently in the University of Oxford, focusing especially on evaluation, rights-based development of mental health care in the voluntary sector. She's had many roles, including in commissioning and service system development. And a question for her is, how can acute care be improved by working in partnership with the voluntary sector, and can research support this? So if you have 3 minutes.
3 minutes. Thank you, Sonia. Well, I suppose the headlines are first about how we think about needs and we conceive of what people actually need and want. And some of the presentations earlier talked about that, that people want a humane, compassionate response when they're at their most vulnerable. And I think the second thing is around actually understanding and valuing the voluntary sector It's not a poor relation. I think we've again heard from the presentations this morning that it's a vital component of a system. And I'm going to say something briefly about what the voluntary sector offers. And I think the third thing is really around investment in the voluntary sector. Alan talked about the lack of investment in research on the voluntary sector, but there's a general challenge in terms of the voluntary sector, whilst it might be valued, is often subject to kind of funding that is short term and not sustainable, which is not only problematic for the voluntary sector, but it's also confusing for staff working in public sector services, because they get confused about who to liaise with and build partnerships with. So what does the voluntary sector offer? Well, it's offering something that's very distinctive from public sector services. So a crisis cafe run by the NHS arguably will look different, and maybe this is a focus for research, from one that is run by the voluntary sector, because the voluntary sector is informal, it's more accessible, it's often engaging with people from racialized, marginalized communities. It has a set of skills that aren't necessarily in the NHS, because it is working with asylum seekers or knows how to link people with benefits advice, or it's working on housing, addresses kind of domestic violence, a whole range of skills that I think where we see the kind of interest in the NHS and social care and trauma-informed care, actually there's a whole range of assets within the voluntary sector. It's more flexible in terms of kind of being able to innovate, and it's close because it's closer to community needs. And often the voluntary sector services or support is actually by peers, people who themselves have had the lived experience, whatever that is, whether that's service user use or coming from a racialized community or being a victim of rape. And there's been, I mean, I could go on about this. We've written extensively about this, so I won't, because I've only got 3 minutes. But the other thing it does that I think is really, really critical and also misunderstood is that it plays a vital role in terms of collective advocacy and independent individual advocacy, as Jackie's mentioned. So in terms of research, I think what we need to be looking at is how can the partnerships between public sector services, NHS and social care, and the voluntary sector be strengthened through kind of investment and understanding, but also how can we make sure we don't compromise the value of the voluntary sector, so we don't over professionalize it and have, you know, make it work to kind of guidelines or outcome measures that have been developed through research academies and the kind of public sector, but actually fundamentally undermine this distinctive nature of the voluntary sector.
Thanks. So our next panelist is Nicola Evans, who's a reader in mental health nursing at Cardiff University and has a long and interesting track record of research, service development, practice and advocacy in relation to children and young people's mental health care. Question for you is, what should research and policy priorities be for improving acute care for children and young people? Thank you for 3 minutes again. Thanks.
Thank you, Sonia. This morning, we heard a little bit more about the difficulties with signposting and access, and those continue to be the major issues still for children and young people's mental health. You know, accessing service. So families and young people will still say they don't know where to go and they don't know how to access service. So in a recent study that we did when we invited feedback from children, young people and their families, they talked about having to get coached or enhance the stories that they were telling in order to be ill enough or needy enough to be able to access services and to be able to get to the top of the, you know, ridiculously long waiting lists that there are for services. So that's inherently wrong, isn't it? So both signposting and accessing. We also know that when young people, children, young people become unwell and are unwell for a period of time, then they miss out on all those developmental norms that one expects in particularly adolescent years. So they miss out on psychological development, they miss out on social development and educational development, and they fall behind. So, and it's very difficult for them to catch up, particularly socially with peer groups and educationally, because they get offered a reduced list of academic opportunities because of their mental health issues. So it does take them a long time to catch up. So I think it might be useful to do some research that looks at how do those young people fare later in life? How do they manage to catch up? What are the opportunities? And what alternative provisions we need to put in place to allow young people to make up that ground? And I think the other thing is thinking, we've talked a lot about adult services this morning. We do have an emerging set of services that have been influenced by the early intervention psychosis models that have been around of youth services. So we are seeing the emergence of those for young people aged 14 to 25. We don't yet know how they work in comparison to children and adolescent services. And certainly there's different views about whether they're acceptable, whether they're effective, and whether they're cost effective. So, so I suppose research looking at how that fares would be helpful. I've recently been working on a grant application, actually, looking at the services for those young people who are seldom heard. And by that, I mean people who identify as either from refugee and asylum seeking communities, or identify as from Black, Asian, minority ethnic, or care experienced, or LGBTQ. So children who identify from those groups have a poorer experience of access. They have more difficulty accessing services. The services less likely to meet their needs, and they're less likely to engage, probably because the services don't offer what they want. So definitely more research in that area. Thank you, Sonia.
Lovely, thank you very much. And last but not least, Andrew Grundy, who's our Prue Lived Experience Lead and is a postdoctoral research fellow with roles both at Manchester University and UCL, and an extensive record of research and training from a lived experience perspective. But Andrew, the question for you is, how can we better integrate perspectives of lived experience experts in acute mental health care research, and how can we support those experts to contribute? Thank you.
Yeah, great question. Thank you. That's fine. So I want to go back to just how fundamentally disempowering acute care spaces are for service users in these settings, and just how, you know, I've been at my most distressed, my most traumatized, my most unwell, and yet you overhear staff saying, "Oh, don't listen to Andrew, he's being delusional, he's paranoid. Our voices are not documented well in care plans and risk assessments." And sadly, sometimes research organizations, research agendas, research teams replicate those same dynamics through tokenism, through exploiting lived experience voices to tick the box. You know, you've done the right thing. And I think we have to take those kind of dynamics head on and expose them, acknowledge them, and seek to change them. So some of that is around thinking about how we think about madness. See, in my psychosis sometimes comes out as technophobia, paranoia around surveillance. Now, you could see if you were going to do something unthinkable, like put cameras on inpatient units, you could see how that kind of insight could make a real difference. That something so irrational, something so mad, could actually be a really helpful insight in research, design, conduct, ethics, and so on. So it's about recognizing madness as a form of knowledge, wisdom, insight, expertise, and working within that kind of frame. It's about centering our voices so that we're heard throughout the research process, from commissioning all the way through data collection, data analysis, dissemination, evaluation, so that we're present, our voices are heard, we have meaningful influence. It's about addressing these issues of power, and that's both empowering us, so that might be through training in research methods, research design. It might be through meaningful supervision, mentoring, support, and having lived experience experts doing that training and coming alongside people and giving them that support. And also about, it's not just about empowering us, but it's also about traditional researchers relinquishing some of their power. And that might mean that at times taking a step back and asking ourselves, who is the right person to be doing this kind of research? And I'd argue that, particularly if we're looking at service user experiences, service user perspectives, then those sorts of studies in particular should be led by service users. And so I think if we start addressing some of these issues of power and explicitly reflecting on our values and how we think about madness and knowledge, then we'll go a long way to making some changes. And we've started to do that at the Pro, haven't we? So.
Great, thank you very much. So before we have questions, haven't had any time for applause between contributions, so thank you very much for that. So yeah, thank you. Those are very powerful and helpful contributions. Questions from anyone in the room or on Zoom? Yeah. Let's start with Zoom.
Zoom.
Yeah.
This is from Shmuel Yerushalami, and they've said, what according to you are the opportunities created by the COVID-19 pandemic for improving acute mental health services in the UK?
Anyone? Rachel.
So I know in my area, they actually responded significantly faster to COVID than they did to the things that we had been asking for a while. So within maybe a month, there was an alternative to A&E where you could go in a crisis setup, which is something that, we've been talking about for years. So I would hope that there's maybe some learning there about the urgency with which things can happen, like when the chips are down, and maybe making it so that the chips are down a bit faster when it's us asking for something.
Anyone else? No. Anyone in the room? Yeah. Alan, we need to give you a microphone.
It's just a question, not a comment.
It's just for the people online, they won't hear.
It's a new question.
Okay, yes, please.
Oh, okay.
Yeah.
Apologies. Hi, I'm Clarissa. Thank you very much, panel. We haven't heard much about diagnosis today, and I'm conscious with Rachel and Andrew's own experiences, they're very different, and there may be different needs in terms of crisis. And this is also multiplied if you're talking about comorbidities in terms of people presenting with more than one mental health condition, not necessarily talking about physical health. So I guess it's a question to you about whether there needs to be a more personalised provision in crisis care, or if perhaps the more important element is the more emergency element of it, and actually moving into diagnosis and personalised need is a secondary element.
Karen.
Well, I think that's why the contribution of the voluntary sector is so valued by service users, because it isn't starting from a point of diagnosis. Obviously, those organisations have approaches to risk in place, but the focus is very much on kind of the personal experience, and you can't generalize. Voluntary sector is hugely diverse, and I think what we heard this morning was a fairly narrow understanding of the voluntary sector contribution, because it was only about crisis specific services or alternatives to acute inpatient care, maybe, or acute inpatient support. But I think where the voluntary sector helps with that personalised approach is in terms of the social context, social deprivation, inequalities, contravention of rights or promotion of rights. And I think it's when we thought about thinking about what a mental health crisis is from the experience of the people, co-researchers and the people that lived experience who took part in our research, they didn't see it as a kind of, if you like, an illness event. They saw it as a bit of academic jargon, if you like, but a biographical disruption, something that had interfered fundamentally with their life, and that actually part of it was about kind of rebuilding, reconnecting, addressing the sources of trauma, the inequalities, the unemployment, the bereavement, the whatever the particular circumstances were. And that's why I think we, you know, if we're really going to make some progress on this, that we've got a lot to learn from that kind of approach.
Anyone else? Andrew?
Yeah. I guess part of the problem is that there are these sort of biomedical sort of thresholds that you have to reach to sort of enter these spaces sometimes, and issues around risk, and then sometimes our perspectives again are sort of marginalized, and so in terms of, my PhD was looking at risk assessment and risk management on an acute space, and just how a lot of service users coming into the spaces, their primary risk, how they framed it, was around just the fear that they were facing from, say, their psychotic experiences, for example. And those sorts of things just weren't being taken into account because it didn't fit the biomedical framework. And I found that professionals relying on just sort of distraction techniques, PRN, for managing voices, and just waiting for those things to kick in rather than providing sort of therapeutic help and support around, and this is where sort of trauma-informed approach, I think, could begin to make quite a difference in these kinds of spaces. So I think it is about thinking more broadly and thinking about what we can offer people in terms of therapeutic help and support, and the kinds of things that bring people onto the ward that they're looking for help and support for, because it's often those primary things that just don't get the attention that we want them to get, really.
Another question from the chat is from Jeremy Clark. So the current state of acute services is harmful not only for patients but also for frontline staff, yet we rarely hear the voice of staff in research projects. How can we hear more from staff experience in acute care?
I suppose I'm just mindful. There's a few different agendas here and there about staff experiences, but in the studies that I've been involved in, when we were looking at services for children and young people, then getting feedback from people who work in those services or manage services has been always part of that. Not in a what's the experience been like for you and how have you been affected by it, but more how do you think this could work differently, better? Yeah. That's more that kind, but I think there's a whole other agenda as well, isn't there?
I guess from a services perspective, it can be I suppose it feels like when you're on a ward, say, the staff voices have so much more power than yours. It can be quite hard to hear that they're like underrepresented. And I think, yes, obviously the system is harming staff too. I think one way of maybe thinking about that stuff without failing to acknowledge the levels of abuse that some staff perpetrate against service users is there's work that Hel Spandler and Mick McEwen have done on restorative justice approaches, which I think would be worth kind of considering. I think that kind of approach, yeah, acknowledges kind of moral injury as a form of harm that staff experience, but also, yeah, it kind of grapples with those difficult realities and perspectives.
Just wondering, Alan, if you have anything to add on this issue. Thank you very much.
No, I was sat here thinking of Mick McEwen's work as well, and I think it's a really difficult and sensitive area to get into, because I think when service users understandably feel incredibly disempowered within the mental health system, it's quite hard to hear the likes of nurses go, "Yeah, well, we're disempowered too," but it is a reality, and I think I think what I like about Mick and colleagues' work is that his is very much about opening spaces for dialogue, which I'm a big fan of. So I think any opportunities we can get to generate and support spaces where service users and staff can converse together and find joint solutions, co-produced solutions, I think are advantageous. But I think that needs to be done carefully and with good facilitation, because there are sensitivities around those dialogues.
Thank you. Yeah. Anna.
Another question. How do you think research might take account of some of the current challenges to alternative or improved provision, including overstretched public services, community and voluntary organisations that are often struggling for funding, especially if they serve underserved communities, a cost of living crisis that can make it harder to cope outside hospital, and what might be described as a hostile environment for many minorities at the moment?
Acknowledge the strength of all those points, but anyone, yeah.
Well, I suspect, and if I'm allowed to say this, that the solution is partly political, highly political. The environment in which we find ourselves is beyond hostile. And I think the swinging cuts that have been made to local authority services have impacted on support and funding for the voluntary sector, which is maybe why we're seeing quite a narrow focus of the voluntary sector and its purpose being about to help reduce detentions or, people turning up at A&E. So I think it's a highly political question in a way, and I guess you knew that. But I think the other thing is we really need to look at the kind of costs here, the human costs, the financial costs, and look at who is and who isn't getting access to services. And so, I mean, one of the things I think a couple of people on the panel have hinted at is this notion of crisis support as a system. And so you have to invest in all of the bits of the system, and there are imbalances of power in the way in which funding is allocated. So yeah, I don't know if that kind of helps answer it, but
perhaps also just adding, I think Paul McCrone would explain this much better than me, but I guess we're a long way from being able to implement this, but it is a feature of mental health care systems that if you can reduce inpatient use somehow, you actually can free up quite a lot of resources, and good community alternatives can be significantly cheaper than inpatient care. So that's an opportunity, I guess, but I certainly agree about the political part, but yeah.
Yeah, I mean, I think we have to just not shy away from the fact that we're living in like apocalyptic times. And, you know, I said earlier, like after the revolution, we'll be starting from a very different point. And I was kind of only half joking, like, and I think it's it's realistically, it's hard to like bring personal radical politics into research. But what am I trying to say? I think we just have to like, where the data that we're collecting shows that there are political problems, then like, or political causes of people suffering, then I think we have to say that and not shy away from it.
Alan.
So just linked to that, Bobby Prattup, who was hoping to be couldn't make it. Yeah, I was getting political, got cut off. I know what they're like. Yeah, he sent a message and saying one of his reflections on his time working in NHS England was that he felt they did put a lot of investment and a lot of support to developing more crisis services, and many of those were successful, but they were successful in that they attracted a lot more people into those services. And he felt that we need to go much further upstream, and actually what we need to start doing is addressing some of the structural systemic causes of mental distress in our communities to head off the feeding into those services much sooner, much earlier. And I think, interestingly, I think some of the renewed, or the hopefully new focus on children and young people, which again are also, their services are also being overwhelmed, but I think the focus on that much earlier intervention, and it breaks my heart to think of children experience mental distress, families at their end of their tether, and then they're on 18-month, 2-year waiting list to be seen. When I see my grandchildren, how quickly they develop in a matter of weeks and months, I mean, that is just frightening. And I think we need to put a lot more in a lot earlier.
Can I just add a little bit onto that? So I think the other thing to remember, of course, is that particularly children, young people, and their families, that help comes from lots of directions, not just from health. You know, it's education, youth, family, friends, church, social networks, third sector, hugely important. Health is a specialist. Mental health services for children and young people is just one tiny portion of the whole package. And I think if we can find more, generate more evidence to demonstrate that, it will ultimately help with funding of those other services.
Great. Thank you very much. I think we've run out of time, unfortunately, but thank you again to our panelists for all they've shared, and to our earlier presenters.